Okay, good morning, everyone. My name is Ruth Cologne Wagner, and I'm with NIAPRS, the New York Association of Psychiatric Rehabilitation Services. So good morning and Happy New Year, and welcome to our fifth and last content webinar of our care management training. That being said, I don't want to confuse anyone. This is just a gentle reminder that while this is the last content webinar, the supervisors involved in this training will continue to be needed for a few other activities as part of the Supervisory Learning Collaborative, and I'll go over what those dates are in a few minutes. So for all of the care managers out there, on behalf of NIAPRS and our partners, we'd just like to extend a real huge heartfelt thank you for participating in our training for these many months. And so as you know, if there are any webinars that you have yet to watch, you will find them archived on the Learning Management System, and we urge you to watch them sooner rather than later. As our training comes to a close, this is becoming increasingly important. So this care management training, as you may or may not recall, is being offered to the care management community of New York State thanks to a grant from the Department of Health. And as part of that grant, we keep records of attendance at each webinar. We ask that everyone watch and mark each webinar complete if you haven't already done so. We will continue, you may have noticed, we send out emails periodically. We will continue to do that, and within the next few months, we will reach out to you, reach out to everyone with reminders. We'll do that by email. We'll also do that by phone within the next month, and just serve as reminders to watch any webinars that you've missed. And so it's that time when you see those emails or we have those conversations and you realize that our records are not accurate, and that you did indeed watch the webinar, please email me, call me. My email is ruthcw, so it's ruthcw@niaprs.org. That is ruthcw@nyaprs.org, and we'll make those corrections immediately. So as I briefly indicated earlier, there are going to be a few more activities left in this training initiative for the supervisors, and the schedule for that is the next Supervisor Learning Collaborative call is on January 19th, and then we have 3 regional report back supervisory calls, and for Western and Rochester region, that's on February 23rd. Central and Utica is February 24th, and Northeastern and Northern Metro is February 26th. And then we're wrapping up the entire training initiative. The last 15 months, all supervisors are coming together the way we have done periodically throughout this initiative. And the Western and Rochester region supervisors will get together on March 22nd. Central and Utica Watertown supervisors will get together in person on March 23rd. And Northeastern and Northern Metro will get together in person on March 24th. And we ask that you continue to look at your emails. And if there are any changes in that, we will be informing you by email. So with that being said, I'm going to continue onward and upward. Today's webinar is entitled Workload Management and Using Technology to Enhance Productivity and Effectiveness. So as always, all attendees are muted in order to reduce the possibility of just too much noise on the line. However, of course, we want to hear from you. So for questions, please use the chat box throughout the presentation, and we'll be sure to have time to get your questions answered. So joining us today are our partners from the New York Care Coordination Program, Adele Gorgeous, who's the Executive Director, Don, who's their IT guru, Diane, and Cheryl. And from the Center for Practice Innovation, we have Paul Margulies and Nancy Covell. Today's presenters are Jason Covey and Nicole Brill, and I'm going to give you a bit of their bio right now. Jason is the Chief of Finance and System Accountability for the Monroe County Office of Mental Health, and there he develops and manages the annual contracts between the county and Coordinated Care Services Incorporated, or CCSI. So within that contract, Jason oversees the development and implementation of their annual contracts with the community, not just of CCSI, but also behavioral health providers on behalf of the county. And that includes development of performance metrics to support oversight and monitoring of the behavioral health community. In addition, he directs and supervises the Monroe County Financial and Data Quality and Accountability team. So Jason received both his bachelor's and master's degrees in applied statistics from the Rochester Institute of Technology. And there he was also an adjunct lecturer from 2008 to 2013. Our second presenter today is Nicole Brill, and she is a senior consultant of health information technology with CCSI, and she leads the work of healthcare information technology and data management for them. She works closely with a broad range of CCSI staff and customers in order to assess their health information technology needs. She defines requirements, evaluates solutions, and supports system implementation efforts, so with a specific emphasis on achieving operational effectiveness. Before joining CCSI, Nicole was a senior health IT advisor with Innovative Solutions, where she provided consultation and technical assistance to healthcare organizations in order to optimize their healthcare information technology. Nicole holds her Master's of Science in Healthcare Administration from Robert Wesleyan College. I think I got that wrong. Wesleyan. There you go. So with that, I now leave you in the very capable hands of Jason Covey. Thanks so much. Jason?
Thank you, Ruth. And on behalf of myself and Nicole, we appreciate the wonderful intro here. Happy New Year, everyone. Hopefully your New Year started off on the right foot here. What we'll be talking about initially is to focus on a tool to help providers assess their current and potential adult health home fiscal models. In the ever-changing behavioral health landscape, it's critical to have an appreciation for various components that drive the fiscal viability of programs. With health homes one of many newer initiatives, this tool may be helpful in understanding one's program and the programmatic opportunities there may be in running a viable health home program. So we'll first start by talking a little bit about the expectations of the health home fiscal tool that we'll be going through here today. The tool that we'll be reviewing allows a user to start by building their current state health home program or project the program if new to health homes. To do this, user input on certain variables will be necessary, and we'll go through each of the various variables that you have the opportunity to input into the tool. The tool will allow for an initial program to be compared to a future state program. So you'll kind of look at business as usual as of today, taking into account the newer health home billing of high, medium, and low rates that will take into effect in September of 2016. This will help former TCM or targeted case management providers project the health home revenue that they might generate after the legacy billing sunsets at the end of August of 2016. So a quick overview of the components of the tool, specifically related to the necessary user input. It'll first start by a selection of the provider location. Okay, so it'll either be upstate or downstate, and we'll get into the actual tool itself so you can kind of see how these work in a second. The upstate and downstate designation will impact the rate structure that will be incorporated into the tool itself. The next component is the average monthly health home enrollees. So this is overall for the program. Next is the expected distribution of the program acuity levels. So this is taking into account those high, medium, and low, HARP or non-HARP, Health Home Plus or Outreach, and the distribution of those individuals within a program across the program itself. The next component will be related to cost, so various input areas on salary, fringe benefits, all other costs, and opportunities to include a health home administrative fee cost as well as a managed care organization fee, if applicable. We also will be inputting the caseload size per acuity level as an input for the tool. To give you a sense of what the tool will be doing and where you'd be inputting some of this information, the input areas are in the green, and we'll slowly kind of work our way through the model and where these input areas are necessary and how it drives the calculations of the tool and how it can be useful and moving forward and assessing the fiscal viability of your program. So the first area is in the upstate or the provider location. So this is defaulted to upstate. So the options are upstate or downstate. We'll drive the rates and you'll see that in a second. The next component would be the size of the program. So the average number of total individuals enrolled in the program at any given time. So in this case, we've defaulted to 100. So all the input information in this example right now up on the screen is just for show purposes. From there, it's understanding from those 100 individuals per month, what is the acuity level breakdown associated with those 100 individuals. So it breaks down into the various high, medium, and low rates associated with the September 1st start date. It also includes Health Home Plus as well as outreach. The total of those percentages should equal 100% or should accumulate in all 100 individuals that are being served per month. So that's the first section that we would be putting input into the tool. The second area that we're looking at is the cost input. So what this takes into account is the average care manager salary. Okay, so in this case, we're defaulting to $40,000. Okay, so this would be whatever the average care manager salary is for your provider, for your care managers. There's also an opportunity if the average outreach worker salary happens to be different. It may not in your organization. This could be 40. In this case, we've got 40 and we've put in 35. From there, we're looking at building the total compensation package for an average individual in the care management program, in this case the fringe benefits. So as a percent of salary, in this case would be 30%. This would be whatever your organization has as a fringe benefit rate. So talking with your fiscal folks might give you that percentage if you're not sure. The other component is now building the fully loaded costs associated with one care manager FTE. So in this case, we're taking into account overhead and all other costs associated with that FTE. That would be as a percent of salary and fringe. So again, this might take some work in working with your finance department or your fiscal folks to figure out what that percentage may or may not be. In this case, we've defaulted that to 50%. So that would take into account 50% of 40,000 times the 30% of fringe benefits. Building your fully loaded cost. The other options here for costs are associated with a health home administrative fee done at a per member per month. So basically taking into account that we've got 100 individuals in the program at a month, $10 per member per month. So that's adding up to your building the costs associated with running your health home program and what you would have to pay to a health home as their administrative fee. The other component that may or may not be applicable is if the individuals are associated with a managed care organization, there may or may not be a managed care organization fee. We've built this as a percent of revenue. So this 3% would be calculated by whatever revenue the program is generating associated with that. So that's the first section of the inputs that we'll be talking about. The next section gets into the caseload determination. So you can see the only area in this part of the schedule that has user input is related to the initial expected caseloads. So now we get into a little bit more detail associated with the rates that we've been talking about. So we have the same various levels of acuity, Health Home Plus, the high for the HARP and the non-HARP, medium, HARP and non-HARP, and so on, all the way down to outreach, and the per member per month rates from DOH. This is calculated and inputted here based on the selection from the previous screen that was upstate. If downstate was selected, these would change to the downstate appropriate per member per month rates at the same acuity levels. So they're, as most folks know, they'd be a touch higher. So the next piece that we want to be able to build to understand our fiscal program related to health homes is the initial caseload sizes. So for the Health Home Plus, we're looking at approximately 12 individuals on a caseload. Okay, so these would be your internal caseloads. These are just defaulted for show purposes for the presentation here. And we get into HARP. In this case, we've defaulted to 15. Those could be different in your organization, the medium, the low, and the outreach. The key with inputting these caseload sizes is that will drive the rest of the calculations for the health home tool. It will generate the FTE requirements associated with the program capacity. So we have 30 slots in the Health Home Plus. This was generated just basically by the multiplication of 30% from the previous screen of Health Home Plus times the monthly Health Home enrollments of 100. So that's your 30 individuals in the Health Home Plus category. So based on having a caseload of 12, we need 2.5 care managers to work with those 30 individuals, okay? And that's basically the math all the way down for every acuity level. Same formula. The revenue is basically just taking into account and building off of the program capacity, so 30 individuals that we're working with at any given month for Health Home Plus, times the rate, times 12. That's building our revenue associated with this component of the acuity. Same for each of the various other levels of acuity. The costs take into account the FTE requirements times the care manager's salary, the benefits, the other costs, also taking into account the Health Home administrative fee, okay, which remember was built on the per member per month. So in that case, it would take into account the 30 individuals. And as we go through the Excel tool itself, we'll start to see some of how those formulas work a little bit more dynamic than the static picture that we're looking at right now, as well as a managed care fee, which is built off of the revenue component, if we remember the previous tab. Okay, so again, the Health Home administrative fee per member per month, based on the number of individuals we're working with in that acuity level, and the managed care fee built off of revenue. What that then will allow you to do is see your revenue and your costs associated with each acuity level, and then give you a balance or a surplus or a deficit associated with each acuity. So you can see in this scenario, this program would be making money in the Health Home Plus and starting to lose money or have a deficit in the various other acuity levels. So then you might start thinking, well, how do we change that or take that into account as we're planning for the fiscal viability of our program? Because if we look down below, we have 5.5 total FTEs for our program, working with 100 individuals per month on average, and we have a loss to our organization for this service of about $3,000. So then comes in the next components of the tool and how you can play with some of these variables to start to build a fiscally viable model. So just kind of a quick review of what we were talking about. The tool calculations, so we initially talked about the input associated with the tool. The calculations that are being done based on the provider input are the FTEs required by acuity type. The slots or the capacity associated by acuity type. The revenue and the cost by acuity type, as well as the net or the surplus and deficit that would be generated by acuity type. The next component of the tool allows for some additional input options. So this would kind of be the area of the tool that you'd be able to play. So you've built your initial or today program, how things are working right now with your various size of your program, your acuity levels, your costs, as well as the caseload sizes that are happening today. Now what you might want to be thinking about is, well, what happens if those caseload sizes change? How does that impact my bottom line? What if I change FTEs? What if I grow my program? How would that take some of these things into account to take a look at the impact fiscally to my program? So this second section will allow us to do that. So the second section that we're looking at looks very similar to the first one with a couple of different user options. So the user options here now are the caseload options, same as before. So this will default to what was inputted above, and then you have the option to change it. So you can see Health Home Plus 12, our highs are at 15, 20, and 40, and so on. So the same information as above. This would be the section where you could play with some of these caseload options. So obviously if you're increasing your caseload size, you're not having an impact on costs related to FTEs, but you would be able to generate some additional revenue. So that's what you might be thinking about as you start to run through some of the options here. The FTE option allows you a couple of different things, to see the impact of growing your program. So as you start to build a viable program, you can see as you have the impact of one FTE, you can see how that impacts your bottom line for one FTE. So as you think about growing your program, you can start to see, well, am I growing it, am I impacting it negatively or as a positive bottom line? So in this case, what we've changed is we left our our Health Home Plus at 2.5, so you can see the same surplus net happening for that acuity level of 45,000, and it just inputted 1 FTE for all of the various other acuity levels, so you can kind of start to see for each acuity level, no change for capacity and no change to cost or anything like that. You could see for each component where we would be losing based on growing our program by 1 FTE, or if we have 1 FTE in our program. So the tool calculations for the second component based on the options are the slots available by acuity type, revenue, cost, and surplus and deficit. The same as the components or section above, with the exception of the FTEs, because we have an opportunity to modify FTEs as well as the caseload size with the second component. So what we'll move into now is really taking a look at the tool itself and kind of walking through the components of the tool. So it's fairly simple. It's only 3 tabs in Excel, and we'll go through each one of those tabs as well as take a look at a couple of different scenarios so you can kind of see how you might utilize the tool itself internally in your organization. So the first tab is really an instruction or description tab, gives an explanation of the tool and some detail around the user-defined inputs. The illustration tab is actually the tool itself. Looks very similar to the static pictures that we've looked at before, as well as a rates tab. So the last tab basically is just where the rates for the upstate and downstate at the high, medium, and low levels are being pulled from. What you'll notice once going through the Excel modeling tool is that it's not protected, and that's so each user has the opportunity to make adjustments, enhance the tool if necessary, so it works best for their organization. Also, if rates change, you could go into the rate tab, make the necessary changes, and then you have a more up-to-date version of the tool that you could be using. We'll go through each section of the modeling tool similar to what we had quickly done through the static versions. We'll take a look at some of the calculations, an overview of any assumptions that we've made in building the modeling tool. We'll take a look at one scenario that looks at a smaller size program of about 100 individuals enrolled per month. We'll take a look at the acuity breakdown assumptions, the cost, caseload, a fiscal outlook, and then some options on how you might build a fiscally viable model for that scenario. We'll also do the same thing with a slightly larger program. So we'll jump from 100 individuals per month to 1,000 individuals and just see how that plays out and how you might be able to build a fiscally viable model there as well. So let's jump into the modeling tool here. Okay. So in the Excel model, the first tab that we mentioned before is really just an instruction or description tab. Gives you kind of an overview of the model itself, gives you some description and input associated with the user-defined variables. So the overview is really what we've been talking about. The user-defined variables, so these would be the ones that are in the shaded or green colored cells. There's the provider location. There's the health home care management enrollees. So that's the number of individuals that will be enrolled in the program per month, the expected acuity level breakdown. And once we hop over to the tool, you'll see exactly where this kind of plays out. The cost inputs that we were talking about, so the average care manager or outreach worker salary, the fringe benefit component, and then the other cost as a percent of salary and fringe benefit. The other components associated with costs are related to the health home administrative fees that we talked about, as well as an opportunity to put in an MCO fee, if applicable, as a percent of total revenue. The next component is that initial expected caseload size, and then we move into the last section, which is the area, again, that I mentioned where you can kind of play with the caseload option and the FTE option to start to see how those may impact your program overall. And then just a comment that I'd mentioned before, that the workbook's not protected or locked, and we encourage folks to play. What you may want to do moving forward is you may want to save various versions if you're playing and changing a lot of the user-defined variables as you move from one to another. Okay. So now we'll hop into the tool itself here. Okay, so this was our first scenario. So in this case, we've taken a look at the provider location. Okay, so in this case, we've defaulted to upstate, and we'd have a drop-down box that would allow us to change from upstate to downstate. And in doing that, we would populate our per member per month rates based on those DOH acuity levels down below in the acuity area. So I'll quickly pop over so you can kind of see that as well here. So it's really a basic third tab. That's the health home DOH rates based on the high, medium, and low acuity factors, taking into account the HARP and the non-HARP for upstate and downstate. So again, that drop down gives you the delineation between the various rates. The Health Home Plus for upstate and downstate, as well as the outreach. Moving back to the Excel file. So what we've been able to do is input 100 individuals for our monthly enrollments in health home care management. And then internally, what you'd want to be assessing is where do those 100 individuals fall based on the acuity level breakdown. So there might be some work needed internally in your organization to understand, based on these new high, medium, and low acuity levels, where those individuals may or may not fall. So in this case, we've defaulted to 10% ended up being in Health Home Plus, about 50% overall in the high acuity level, evenly distributed between HARP and non-HARP, medium 30%, and then 10% or 10 individuals per month in the outreach area, totaling to 100% of those 100 individuals that we were talking about. The cost inputs that we've then inputted in here are similar to the ones we talked about before. So the average care manager salary, in this case, of $40,000. So that would be for all care managers working in the program, the average of those. The average outreach worker salary, in this case, $35,000. Again, it may not be anything different than the $40,000 above, and then the fringe benefit one, percentage of personal service or the salaries above. We mentioned before, again, about the overhead and other costs associated with building a fully loaded rate for care manager, in this case 50%, and you can modify that within the Excel tool as well, again working with your finance department. The health home administrative fee, in this case of $10 per member per month, and the 3% of the managed care fee. As we start to scroll down the rest of the components of the tool, what we have here is the acuity area that's going to start to build our revenue and our costs to build our bottom line associated with each various acuity level. So based on our $700 per member per month for Health Home Plus, we input how many individuals are we going to be working with, 12 individuals. It's going to calculate how many FTEs we're going to need to work with those 12 individuals, because we have, for a caseload size of 12, because we have 10 individuals that we'll be working with, so that's why you can see this is less than 1 FTE. This would have to be 12 for this to be 1 FTE, but we only have 10 individuals based on 100 individuals times 10%. Builds our revenue, our costs from the information inputted above, and calculates our bottom line or our surplus or deficit associated with that level of acuity. The same for our next levels of acuity for HARP and non-HARP. So you can start to see where we might start to be losing money in our breakdown of our acuity levels for this program. So you can see you're slightly losing on our HARP high, a little bit more on our HARP, our non-HARP high, and same for our medium for HARP and non-HARP. As we go down to outreach, we have 10 individuals that we're working with, so we only need about 1.6, 1.7 FTEs based on a caseload size of 60 is actually going to generate a small surplus for that component. So overall, this program is showing for 100 individuals and about almost a $500,000 program, a loss of about $40,000. So now what you then want to be thinking about is, how do I impact that bottom line? What would I be modifying to be able to start to get closer to break even? That's where this bottom area will come into play. The options down below, like we talked about, are related to caseload size, so this will default to the caseloads that were inputted above. And then we have the opportunity to modify our FTE, so it'll default to the FTEs mentioned above as well. What we're running into is the Excel version that we have is not up right now, so I can kind of talk you through how this would work and what you might want to be modifying in here to start to build a viable program. So if we leave FTEs the same, so say we're going to stick with our 5.8 FTEs, what we then would want to be impacting potentially to cut into this $40,000 could be our caseload size. So what you'd have to be thinking internally is how large of a caseload size could our care managers handle to be able to start to get closer to a break-even point. Probably would stay away from your Health Home Plus because the DOH designated caseload size is no more than 12. So you start to think about your HARP, your non-HARP. Those would be the ones that are losing a touch of money associated with the various levels. So maybe it's increasing your non-HARP high from 15 to 18. So if I would have changed that, the impact would be, we'd be making $5,000 as opposed to losing $28,000 for that acuity level. We then might look at our medium for our HARP and our non-HARP. So increasing our HARP from 20 to 22, and these are just arbitrary numbers that I'm throwing out to try and get to a break-even point. It would obviously take a lot more discussion internally on what is feasible within an organization and how many individuals could a care manager appropriately work with to deliver the appropriate level of care. So in this case, if we increase this from 20 to 22, we would decrease our loss from about $9,000 to $4,000. Our medium non-HARP, if we increase that from 20 to 25, that would decrease by about $10,000 from $19,000 to about $9,000 loss. We've now changed our $40,000 bottom line, and I apologize that this is not working dynamic right now, from a $40,000 loss to about $8,100 surplus. So just by modifying some of these caseload options here, we then have impacted the potential of what the program fiscally may look like. Obviously, a lot of discussion has to be taken into account to impact and make programmatic changes associated with what's happened in the Excel tool, but that at least could be the starting point for those discussions within an organization. I'm going to hop over to our second scenario here. Okay. So in this scenario, we've stayed with upstate as our default location. So you can see the per member per month rates have stayed exactly the same. We now have a quite a bit larger program. We now have gone from 100 individuals average enrolled per month to 1,000 individuals. So this may be a former TCM program that has now grown their program with the implementation of health homes over the last few years and now is working with quite a few individuals per month. In taking a look at the distribution of the expected acuity level, again, arbitrary numbers that we have kind of put in here, but taking into account maybe a former TCM, some of the individuals may be falling into the high and medium areas from our former ICM and SCM folks. We have about 3% falling in Health Home Plus, again 50% in our high, and about 32% falling into our medium. Again, this would be internal decisions that you as an organization would be making and populating these areas. Increase slightly the costs associated with the care manager salary as well as the outreach worker. Again, internal decisions and work that would need to happen at each provider level. So $45,000 and $40,000 for the various salaries for care manager and outreach workers. The fringe benefit component that we've talked about, as well as the all other costs, again at 50%. Left the health home administrative fee and the managed care organization fee the same as well. As we start to scroll down, we're now rebuilding our bottom line for this program of 1,000 individuals that you're working with per month. You input your initial caseloads sizes per acuity level. Again, not to be repetitive, but these are the same ones that we defaulted in the various other sections. It would then build your FTE requirements based on the caseload sizes. So now, from the previous program, we were at about 5 to 6 FTEs. We now have quite a bit larger, 54 FTEs to work with those 1,000 individuals. And you can see the capacity based on acuity level. So obviously, we've taken this one a bit to the nth degree to show what the tool can help you to do. But if we look at where we are based on these initial caseload sizes and the size of this program of 1,000 individuals, we're generating just under $4 million. However, based on the information we've inputted above based on costs, we have almost a $5 million cost or gross program. So you can see our bottom line. In this case, we'd have some work to do. We have a $1 million loss that would be happening potentially as of those September 1st DOH high, medium, and low rates taking into effect. So this bottom area would then be critical to start to cut into that $1 million loss. Again, I'll kind of walk you through some potential options associated with this because it's not working quite dynamically right now. So in this case, you obviously would have to start to take into account some options associated with caseload size just because of the magnitude of the loss that we're looking at for this program. So what I had just defaulted to is I had increased the 15 up to 18 for the high HARP caseload size, the high non-HARP from 15 to 20, and increased both of the mediums from 20 to 25. Again, just to start to play with some of the numbers to see the impact it might have into the bottom line over on the right. And in doing that, also started to see which one of the acuity levels did you have the opportunity, while taking into account the increased caseload size, to change or grow the FTEs associated with each. So as we increased the caseload size associated with the high HARP, we started making money. So as we jumped from 15 to 18, this started becoming a positive number. So that maybe there's the potential to work with your health home or health homes to understand demand to see if there's additional high HARP individuals. So that might be an opportunity there to grow your program in that acuity level that could also help your bottom line, take into it and offset potential losses in other acuity levels. So we increased the 16.67 to about 22. We increased the high non-HARP from 15 to 20 and changed the FTE level to 7. The medium, we increased to 25 and then had 8 FTEs and 3 FTEs. Overall, we're still working with about 1,000 individuals, but our FTE level decreased from 54 to 45. I obviously know that takes into account individuals and people that are within your shop, so that's something that obviously would have to be taken into account as you play with the various options associated with it. But to get back to how you would effectively serve those 1,000 individuals with some change in caseload options, you could impact or change some of your FTEs. Again, I apologize that you cannot see the changes that I've been talking about in the screen as we're kind of walking through it here. But those changes would impact the bottom line from about $1 million loss, something to a little bit more manageable of about a $10,000 or $11,000 loss. And as you start to play with the tool, you'll start to see how the functionality can work and where some of these options might come into play. That's just the rates for the adults that we've been talking about for the high, medium, and low. Let's go back to our scenarios here. So we went through 2 different scenarios. One at the smaller level of 100 individuals per month, took a look at the acuity breakdown and assumptions, the cost, the caseload, a fiscal outlook, and other options for fiscal viability. That would be more dynamic, obviously, of working through the Excel version. A larger picture of 1,000 individuals, same options that we have: acuity level, cost, caseload, and then we talked through the options for fiscal viability, changing some of our caseload sizes in the lower section of the tool, as well as the potential for the FTE option as well. So that gives you a fairly quick overview of the tool that would be available in Excel, the various tabs and components associated with it. So an instruction tab, the actual illustration or fiscal modeling tool itself. Again, this is just one tool that can be used to help assess fiscal viability. That could be part of your toolkit in helping to assess your adult health home care management programs. There may be others that can also work in conjunction with this tool. Again, it's not protected and can be modified by the user if they wish. I mentioned before that you could save copies, different versions of the Excel file if you want to play with various scenarios and save them as you work through things. It should allow for flexibility for user modifications and changing the opportunity if rates do change as well. The limitations of the tool a little bit are it doesn't take into account outcomes in any way, shape, or form. So you'd obviously want to be taking that into account as you're assessing your overall health home program. This is really just associated with the fiscal components and inputs associated with the program, with the capacity or caseload size, the acuity levels and where those caseloads would be, and then the cost components to try and get to a fiscally viable program. I think at this point I can turn it over to Nicole Brill, another senior consultant from CCSI, to continue our presentation. And what I can do is pass the ball over to Nicole.
All right. Can you guys hear me okay?
Yes.
Perfect. All right. Thank you, Jason. As you mentioned, my name is Nicole Brill, and I am a senior health IT consultant for Health Homes of Upstate New York. And I'll be presenting on the technology to enhance productivity and effectiveness. So the learning objectives for my portion of the webinar today are to learn the benefits of using technology to drive outcomes, and then also the tools to leverage technology to engage your enrollees. I just want to preface this with the fact that some of these tools may not be accessible to you through maybe your agency or the health home that you work for today, but they are just possibilities in which you could utilize to help with the services you provide to your members. I also don't get specific with mentioning vendors or actual names of the applications, just because I'm vendor agnostic and I want to make sure that these aren't seen as recommendations for specific tools through the vendors. All right. So health information technology. A lot of people think of health IT or health information technology as your electronic health record, which I'll refer to as the EHR throughout the presentation. EHRs and care management systems, I'm sure most of you know that these are a little bit different, especially if you're using both an EHR within your own agency and then a care management system through the health home. But they essentially serve the same purpose, which is documenting the services you provide to the individuals. But there's more than that to health information technology. We also have Health Information Exchange, which is also referred to as a RIO, your Regional Health Information Organization. And I'll get a little bit into how you would utilize the Health Information Exchange today. Secure messaging, it might not seem like it's a health IT system, but really is embedded within the core components of health information technology and should be utilized for any type of communications that are sent electronically, and we'll also dive into that a little further towards the end. Patient portals, these are typically utilized with an electronic health record, and these became popular over the last couple of years with Meaningful Use Stage 2, which really kind of enforced the implementation of these patient portals, mostly in your medical setting. Behavioral health is now kind of just getting on board with meaningful use measures and adoption of electronic health records. So these will become more and more prevalent as you, in the future. You probably, as a patient yourself, have seen patient portals maybe through your doctor or through a health system when looking at your lab results or following up with communication with your provider. So they come in various ways. They're usually just, a website or something, or maybe an app on your phone that you can get into and see some of your records. Consumer medical devices, these are known as like your blood pressure cuffs, your glucometers, maybe a heart rate monitor, things like that, that really the consumer is responsible for running them within their own home, their mobile devices. They don't always necessarily talk in a sense to your provider systems, but they help you monitor certain things like your diabetes or your blood pressure at home. Consumer e-health tools and apps. These are really known as like your wellness devices or wellness apps. And these I'm going to get into a little bit further in the future, but these are pretty important and they really could be utilized with your clients today, your members today. And there's a lot of free ones out there that you could take advantage of, as well as those that you obviously could pay for that would then integrate with your care management system. We also have population health tools. These are really utilized with claims data. So these are large systems. Not many people have adopted them yet, and we'll get into those in a little bit. Decision support tools. These, again, were driven really by meaningful use and are typically embedded within an EHR or a care management system. Some care management systems have them, some do not, but they would be something like based on a diagnosis or an age range, a gender, things like that. It would then produce kind of a task list or to-dos for you as a care manager to follow up with your members regarding that diagnosis or a specific age range. Telehealth, I also refer to these as e-visits. These are still kind of spotty. They're acceptable here or there. A lot of them are part of grants right now. They really need to figure out the payment models for telehealth. You have a lot of telehealth services that aren't necessarily provided like through your direct provider, but they're web-based and they charge a certain fee, and then you can do telehealth visits outside of your insurance. But more to come on that, and I think that they will be much more popular in the future. I also put social media down just because I know I've had a lot of questions with health homes of upstate New York that I wanted to address today. And social media can be used in certain aspects, but I just want to make sure that you're using it more as a health and wellness kind of tool. Maybe like on Twitter, you can have a lot of accounts that send you health and wellness tips, things like that, that you could then engage the members in. But using it as a tool really to communicate with your members, not so much, and I'll get into that in a little bit. All right, so the first thing I have to discuss, obviously, would be the health home care management system. All the health homes in New York State were required to implement a care management system and then provide that to the care management agencies, as you are all aware. And really I want to talk about it not so much from a documentation perspective, but how to actually utilize the data that you're putting into the system, knowing that it's going to be a little bit different depending on which health home you work for, what they require you to document, or what they, automatically feed into the system for you. But really just using it in a couple different ways. So one, really utilizing that golden thread that's embedded within a care management system. Most behavioral health systems and care management systems are a little bit different than your typical medical EHRs because they have this golden thread, which allows you to really connect the assessed needs, so through your comprehensive assessment, to the care plan, and then to the interventions that you provide within the activities. And all of those should really be linked within the system. Some systems do this, some don't. So I just want to make sure that I'm mentioning that. But you can do that too manually, I guess, making sure that the needs in your comp assessment are then addressed on your care plan. but then are addressed within your day-to-day activities that you perform with the member. So if it's all, the golden thread is embedded within your system, it really makes it much easier to track the success of those interventions and then tie them back to the needs. And really not viewing the system as a burden on your day-to-day work, but utilizing it effectively to help improve these outcomes. So quality measures, reporting obviously is a big thing within the care management systems that you're going to want to take advantage of. So quality measures, there's a couple different ways, again, that you could do this. It really just depends on your health home. Some of these measures might be through interoperability with a health information exchange, or it might be manual entry on your end. But think about really what is the most important for you to document and track that could then produce the results for you in the future. So tracking ED and hospitalization utilization, obviously something that is a major part of your job today as a care manager. And by doing this, you could find out about the ED and hospitalization through the RIOs, which I'm going to get into a use case in a minute about how to do so. But whether you feed them into your system, so maybe it's interoperability, or you document them manually, you could still pull reports on that and make sure that you're trending hospitalization utilization. The tracking alerts, most systems will have alerts and to-do lists and tasks, so provider follow-up. Instead of using your appointment schedules, let's say for appointments with your clients, maybe you use them to track the appointments that your clients have with external providers, put a task on that, and then make sure that you're calling your patient before their appointment. You can also track tests, the lab tests that are due, medication refills, and so on. You can measure the effectiveness of interventions by trending the length or success of interventions. So how often are you updating your interventions on your care plan? And what are the effectiveness? So did you discontinue them because the client no longer wanted to work on them? Or were they successful in completing those? For reports are going to be different depending on which system you use and what the health home offers. But you really want to use reports for compliance purposes. So DOH has a set of standards, health homes have a set of standards, and then obviously your billing requirements. Caseload by acuity and services by acuity. So you can make sure that your care managers are really able to do an effective job. If you look at a caseload and somebody has, 15 people who have high acuity, then you're going to want to make sure that you're maybe redesigning their caseload structure and giving those to other individuals. And then sharing of a care plan. Obviously, this is something that is required by New York State DOH, and electronically exchanging the plan of care with care team members is difficult today. There are some barriers to this, just because consent models within RIOs are different. Electronically exchanging provider to provider is very expensive. So this is going to be a little bit different depending on which health home you work for. Trouble here. There we go. So health data exchange by the members. This is just really proving my point that the health data exchange, so exchanging the plan of care, not necessarily completely realistic today to do this provider to provider or through a health information exchange. So if you look at the numbers, and this I got from ONC, If you look at the numbers exchanged within an organization, it's getting a little higher. So we have like 34.6% with any exchange inside of an organization. But if we look at exchange really outside of an organization, it's only at 13.8%. And this is because, again, it gets very costly to do exchange from organization to organization. We have different systems involved. You have certain data protections, so your CSR data or HIV data that you have to take into consideration, especially when sharing care plans, and also consent if the patient actually gave consent to exchange the data. So this is just kind of showing you that although there are standards out there and there are requirements, there are still a lot of barriers in exchanging data electronically. So health information exchange, some of you also know this as a regional health information organization, so your RIOs. Throughout the state, there are different RIOs, and they're all offer different services. They are supposed to be standardized in the near future, hopefully, but each of them can really have their own consent model, their own financial model, so depending on how they charge you or if they don't charge you. For a majority of the services, they can't charge you, but then there are some services that they can. So it really just depends on the RIO that is within your region. But this is probably, out of all of the resources that I'm going to go over today, the best resource for you as a care manager. And for the most part, the services and the information should be free to you. So the RIOs are where you can look up hospital and emergency room alerts and information. So they have discharge information, discharge summary, diagnosis, things like that. The lab results. So if you want to make sure that your diabetic patient is getting, their A1Cs tracked, then you can make sure that you're going to the RIO and looking there instead of necessarily relying on the providers to give you that information. Medications are available in some. Client demographics, insurance information is available in some. So if the information that you get from the state file, the DOH assignment file, is incorrect, then this is just another source where you can look to see if they have a different address listed maybe or a different phone number. And then I have coming soon, and this is really, again, dependent upon which RIO that you're working with, but this will be individual provider visit information. So if I went to my doctor, then you could see my visit summary, which they call a continuity of care document in the electronic world, a CCD. So DSRIP is really pushing this to make these available within the RIO. So hopefully in the next few years, you will see more of these. Depending on which HIE you use, the client consent is required. Some have a community-wide consent model in which if the client has consented to one, they consent to all providers who utilize the RIO, and then others it has to be provider by provider. So just make sure that when you sign up with your RIO, that you're aware of the consent model. So I wanted to design a case study of how you would utilize the HIE today for a specific case or a client. So I broke it down by steps, but hopefully you can get a sense for how or why you would use it. And step one, your most basic, is that you really need to be aware of a hospitalization going forward. I mean, you should have been looking at them to begin with, but with the new high, medium, low billing questionnaire, you actually have to document hospitalization and the dates. So in a RIO, they can provide you with the real-time alerts regarding the EDUs and inpatient stays for your patient population. A couple of different ways you can do this is through direct messaging, which they have available. And it's really just another email account, and they will email you these alerts based on your patient population if they present at an ED. You can also get ADT feeds, and this is a technical term, directly into your EHR. And that would be up to your health home to set that up. The Health Information Exchange, so RIOs really can provide you with discharge summaries, including HPI, medications, your discharge disposition, diagnosis provider, all of that. So it's not just the alert, but then you can also get the discharge summary information as well. So your step 2 would be that you check these alerts on a daily basis to ensure you are involved in the discharge planning process for the individual. Now, they obviously, once you see the discharge, they're already discharged, but it still gives you an idea that, you know, a more real-time alert instead of waiting for the patient to tell you. So identify an area within your care management system that you can document these if it's not an automatic feed, so that the data is reportable. So then you can start trending who presents at the hospital, when, why, and start trending that data. And then you need to schedule any required post-hospitalization appointments as needed and document those in the care management system to confirm individual attended the appointment. If you wanted to take it one step further, if you have a data geek on hand, then, you know, or a QI department, then you could really develop a report that shows all of these hospitalizations by patient, diagnosis, and demographics. And then, you know, kind of start cutting the data into a few different analyses. So are there certain diagnoses that are more likely to be hospitalized? If yes, maybe you start using patient engagement tools or different methods with those members. Are there certain days or times that your patients are hospitalized? Let's say Joe always goes to the ED on Tuesdays. Start working with Joe to figure out, why does he go to the ED on Tuesdays? Is it because his doctor is not open? Is it because he just gets lonely on Tuesdays? So then start developing your interventions according to that. Maybe I call Joe on Tuesdays, every Tuesday to check in, or I let him know of alternative settings of care where he can show up. And then was the patient hospitalized because the patient was not taking medication? Some RIOs will have the medication refill date, some don't, so kind of take that with a grain of salt. But the patient engagement tools or medication reminders could also help with this. So like I said, the HIE is probably your best tool to use right now. That should be available to you in your area. If you have any questions, you can always ask me which RIO you should be utilizing and how to get set up with that. The other different apps and systems that I'm going to go over right now, some will be available to you, some not. So, you know, just think about how you could utilize these. So we have population health systems. These are really utilized by a large network of, you know, multiple providers. So a DISRIP is something that they would look into population health systems. IPA, an individual physician association, ACOs, even just regular like health systems that have multiple settings. So if you think of a hospital that maybe has a lot of outpatient providers and they're all collaborative, then they would probably benefit from a population health system. Health homes would absolutely benefit from a health system or from a population health system, but we don't have claims data. So that's the only thing that would hold us back. And what they do is really, it's just claims data analysis. So they're looking at disease prevalence, they're looking at outcomes, utilization, and population characteristics. Consumer-driven tools, these are something that I would say also focus on along with making sure that you're signed up with your HIE, but we have smartphone apps. I would have to say probably a majority of your members do have smartphones. And really, you can use these to increase engagement rates, and they're really self-motivated, most of them. So you have apps, if you just search in your app store for medication reminders or behavior trackers, or motivational quotes, things like that, behavioral health, you can find a lot of apps that they could download, and then they're responsible really for kind of downloading them and following through with them, but still it's another way to make them a little more responsible for their care. Some of them have interoperability with care management systems, some don't. Most smartphone apps themselves won't, but if you actually purchase a system like Sensi Health, then, which obviously your health home would have to purchase, then that's a little bit different. But again, if you don't have the funds to purchase something, go ahead and just start searching in your app store. There's also wearables and medical devices. These are really to track their own health, their own fitness, so everyone knows what a Fitbit is, the blood pressure cuff, insulin pumps, things like that. They probably wouldn't necessarily go out and purchase these on their own, but if they're given to them through a provider or a grant or something, then you could take advantage of these. This is just an example. It shows you the cost on the right-hand side of consumer-driven tools versus the overall cost for medical expenditures per year for a diabetic man. So it's kind of balancing out a lot cheaper to provide these types of tools to monitor the health and wellness outside of the settings of care. And this is just another graph showing the adoption of consumer-driven tools and the trends. You can see, obviously, from 2012 to 2014, and they are increasing, and this number will continue to grow as more and more apps are available, and as consumers are really demanding more mobile alternative methods to your typical settings of care. The self-monitoring tools, these are really what I've been referring to for the most part. It's just that the ONC breaks them down into 4 different categories: subordinate, structured, collaborative, and autonomous. For the most part, I didn't really refer to any subordinate because we wouldn't have those within the health home setting. But the structured, collaborative, and autonomous, these are what we want because they allow the patient to be engaged and really it's self-driven to participate in these. And then I just wanted to make sure that I mentioned the communication methods. They might not seem like health information technology, but you know, a lot of our communication methods these days are not a typical phone call. They are through texting or emailing. So I have to do my due diligence in telling you that you have to make sure that these are secure communications. If you use a smartphone to text a member back and forth, you know, make sure that your phone has some type of secure app on it that would wipe the data clean should you lose it. Emailing, always make sure if you're sending any type of personal health information or protected health information via email that you are sending a secure email. If you don't have a secure email through your agency or through your health home, then all of the RIOs provide direct messaging and it should be free of charge. And that is a method of secure messaging. Social media. So you have to be very careful with social media. I know I mentioned it earlier as really a way to maybe engage your clients, you know, by signing them up for different accounts on Twitter or Facebook that can give some motivational quotes or maybe wellness tips. But when you're using it as a communication method, you have to make sure that you don't identify yourself or a client as, you know, part of a health home, any type of Medicaid services so that you provide them or that this person should receive them or that they qualify for a Medicaid program. Really identifying them in any way or yourself with Medicaid programs and what type of services in which somebody could then determine the qualification standards for that program, for that patient, you know, you're getting into muddy water right there. So make sure that you're only using it to view information. Some people I know use it during outreach to help them find individuals. That's fine. Just make sure that your communication is not identifiable. All right, I think that is it for me, so I'm going to pass it back to Ruth.
Well, thank you, Nicole and Jason. And we have one question directed to Jason. And for the others, feel free to type in your questions so we can have them answered. So we have a question here. It appears that current clients do not have an acuity level that matches their level of care needs. How are acuity levels amended to reflect this more accurately, as this definitely impacts revenue generated?
Yeah, I think the intent for this tool is to take into account the new tiered rates for high, medium, and low. So basically, this is for implementation of the, September 1st of 2016 methodology for acuity levels. So basically, this would be projecting after the TCM legacy rates kind of sunset at the end of August of 2016. That was the intent of the tool. So I hope that answers your question.
Jason, this is Adele. Let me just add a little to that. With the new MAP system that will be coming in, it is the intention that there be a closer alignment between the acuity levels assigned to an individual and their actual needs.
Perfect. Thank you, Adele.
It doesn't seem as if there are any other questions. Perhaps while we're waiting to see if there are any more questions, let's talk about the tool that Jason introduced. You will be receiving the Excel file with that tool following this webinar. We do have a supervisor learning collaborative call scheduled for further out in January. I'm thinking that you may want to ask your finance director to be on that supervisor learning call so that they can pose any questions they may have to Jason during that meeting.
Sure. That sounds like a good idea.
All right, because I think, while it seems all self-evident to some, others may have questions about how best to use it. And so if you have your finance people, who will probably be the people working with this, on that learning collaborative, we could answer the questions at that time. And in fact, for the HIT section that Nicole talked about, if you have somebody in your HIT department who has questions related to the material that Nicole presented, please feel free to ask those individuals to join you, the supervisor, when you are on the call. Do we have any more questions at this time, Diane?
Yes, another one just came in. What would be the best way to calculate a caseload of mixed levels of care to determine if it is cost effective?
Good question. I mean, you could use the tool and really just start to build that caseload from the various acuity levels and see how things play out. It would really be starting more as opposed to, a one FTE associated with just one acuity level, break that FTE across the various levels of acuity to see how that plays out.
Yeah, as I was looking at the tool, Jason, it gave you a profit or loss by acuity level. So you'd really, if I were the finance director, I'd be looking at how you wanted to adjust either your costs or your caseloads so that each of those acuity levels was at a break even, or at least you had offsetting profits at one acuity level and losses at a different acuity level. And it's a fairly easy tool to use to take a look at what type of a mix, and maybe you'll want to have some levels where it isn't breaking even, but other levels where you're making more money so that your bottom line is one that puts you in a fiscally viable position.
Correct. Right.
Okay, Molly has another question. What resources are available to care managers for information on how levels are determined?
Nicole, I'm thinking that the resources are basically the MAP system and how that system works. As a care manager, when we move to the new high, medium, and low levels, you, the care manager, will need to answer questions in the MAP system that will in turn drive acuity levels for the individuals you are seeing. And so it's familiarity with what those questions are, where you go, how you fill out the answers that will have, I think, the biggest impact on the correspondence between the acuity level and the actual acuity of the individual. So there will be a lot to come on that. I believe that the MAP system goes live for the adult population starting in March, and you have a period of time during which you can be using the high, medium, and low in the questionnaire, but it doesn't actually impact the rates until further out. But you'll have plenty of opportunity to become familiar with it. And do look to the health home with which you are working to provide you with the appropriate information and training on how to use that system.
There also, Adele, there is a webinar on the DOH website that explains the answers to those questions and what would make them high, medium, or low.
Oh, well, there's a better resource.
No, but definitely asking your health home, because some health homes are going to build that questionnaire within their system. Others are going to utilize MAP, but there is a kind of a training period from, I think they said April to October, when you can fill those out, but it doesn't impact the actual rate. So then you'll get familiar with the question.
Okay. Perhaps for the upcoming Supervisor Learning Collaborative, we could have a link to that webinar that we provide to the supervisors.
Okay.
And there are no more questions.
Okay. If there are no more questions, let's go back to the slide deck. Our next steps. If you have joined this webinar as a group, please complete the post-event survey, which is going to appear in a new window immediately after the webinar itself ends. This survey will be your opportunity to give us the names and email addresses of the participants who were watching the webinar with you but were not individually logged into the webinar. It's important because this will assure that each person receives credit for attending and will have access to all of the materials, including the Q&A email. This webinar, as with the others, has been recorded, and it will be available on the CPI Learning Management System. I'd probably give us a day or two to get that up. Contact information, here are contacts for NIAPRS, the New York Care Coordination Program, and for CPI. Questions may be directed to any of those three individuals. And with that, we thank you very much for your participation in this webinar. We hope you have learned something, and we'll look forward to answering additional questions as well as providing additional information on both topics on the upcoming Supervisor Learning Collaborative. So with that, we will say goodbye and look forward to talking with the supervisors later in the month.